Examples of cardiovascular system drugs which with a potential interaction during anesthesia are the angiotensin converting enzyme inhibitors, which might lead to severe hypertension. The same is true for angiotensin receptor blockers. Clonidine sudden withdrawal can lead to a hypertensive crisis. Beta blockers have a negative inotropes effect, and they mask compensatory tachycardia. And the acute withdrawal of these medications may result in angina or ventricular extrasystoles. Calcium channel blockers also have a negative inotropic effect. They might lead to bradycardia, and the acute withdrawal of these medications can exacerbate angina. So what should we do about medication which is taken before surgery? Most drugs should be continued up to and including the morning of the operation. Some adjustment in the dose may be required for some medications, such as the antihypertensives or the insulin, and some drugs should be discontinued several weeks before the surgery if feasible. Examples of these medications are the long-acting monoamine oxidase inhibitors, and the consideration must always be given to the potential consequences of stopping drugs preoperatively and the appropriate advice or alternative treatment provided to the patient. The fifth element of history taking are the history about any previous allergic reaction. And the history of allergy should be to specific substance, such as food, drugs, or latex. And for example, latex allergy requires specific equipment and preoperative management. Allergy to local anesthetic is usually a manifestation of anxiety or a response to peak concentration of local anesthetic or adrenaline. And a small number of individuals are allergic to sulphites, which are usually commonly found in local anesthetic preparation. So an important emphasis about these should be taken during allergy history evaluation. The sixth important aspects of history taking is the history of smoking. The long-term effect of these smoking on cardiovascular and respiratory system are well established, and this might lead to a six-fold increase in post-operative respiratory morbidity. The recommendation is to stop these smoking at least 2 hours prior to the surgery, and if smoking was stopped 6 weeks before the surgery, this will significantly reduce the bronchoconstriction and mucus secretion in the tracheobronchial tree. Also, an important evaluation of obstructive sleep apnea need to be considered on the preoperative assessment during history taking, because this have a higher incidence of difficult airway management and should have a careful observation in the postoperative period. And the gold standard for evaluation and diagnosis of this would be through polysomnography. And if it's not available, screening tools can be utilized, such as the Berlin or the Stop Bank questionnaire. The Stop Bank questionnaire will include these important evaluation, which is a question that can be directed to the patient, such as, do you snore loudly? Do you often feel tired, fatigued, or sleepy during the daytime? Has anyone observed you stop breathing during your sleep? Do you have or are you being treated for high blood pressure? And then evaluation of the BMI index, the age, the neck circumference, if it's more than 40 centimeters, and whether we're dealing with a male or a female gender. And the history risk of obstructive sleep apnea, if there was 3 positive answers to these questions from 8, this will signify the risk during anesthesia as well.